My final DNB in Kaveri Specialty Hospital. Today I am here to present a case of
Start. Visible. Slide is visible, audible. Proceed.
yes, sir. A case of 11 years old girl child from Arilur. She is a firstborn to non-consanguineous parents. Was brought by her parents, whose information is reliable, with chief complaints of generalized swelling of the body for the past 1 week and abdominal pain for the past 1 week. History of presenting illness. According to the mother, the child was apparently normal 3 months ago. Then she noticed easy fatigability in the child. The child was previously very active, cheerful, was more interested in outdoor games. Now restricted for the past 3 months. Now restricted herself to be only inside the house, taking care of her daily routines, but not much interested in playing outside. And history of poor food intake for the past 3 months. Who is very much interested in foods, who used to ask foods, different types, who used to try different types of foods, now not interested in foods, even if the mother gives. And history of weight loss for the past 3 months. Mother noticed the child's dress has become very loose, which she used to wear in the past 3 months. And history of generalized swelling of the body for the past 1 week. It's initially over the face, then gradually progress to the foot. There is no diurnal variation or postural variation. And history of abdominal pain for the past 1 week. It's acute in onset, diffuse and dull aching, more towards the right lower abdomen. It's increasing intensity on the day of admission, and it's not associated with any aggravating or relieving factors, and there is no nocturnal disturbances. It's associated with history of vomiting 1 episode, 1 day before the admission, non-projectile, not blood or bile stain, and contains only food particles. There is no history of fever, loose stools or constipation, no history of altered bowel habits, no history of reduced urine output or high colored urine or rash, no history of breathing difficulty or palpitation, and there is no history of yellowish discoloration of eyes or urine. Past history: the child was hospitalized 40 days ago for generalized edema. There she was diagnosed to have anemia and was treated with 2 doses of red colored IV infusions, and then she marginally improved and was discharged with no oral medications. On further probing, mother also revealed on history of blood-stained stools 1 episode and 1 unit of blood transfusion that was given 1 year ago. Since then, she had intermittent abdominal pain off and on that does not require any hospitalization. Immunization history: she is immunized till date according to nation immunization schedule. Family history: she is the firstborn of the 2 siblings, and there is no history of blood transfusion in any of the family members. There is no history of similar complaints or altered bowel habits in family members, and there is no history of contact with tuberculosis. Her antenatal and natal history was uneventful. Developmental history: now she is on 6th standard with average scholastic performances. Previously, she is very much interested in academics. She used to do her homework by her own. Now, her academics has come down according to the mother. Even if the mother insists on online classes, she is not much interested in studying, and she has not attended menarche. Her diet history: her expected calorie intake is 2000 kilocalories, and her intake is only 1000 kilocalories, 1100 kilocalories, and with a deficit of 900 kilocalories. Protein: she has to take around 33 grams of protein, but she takes only 24 grams of protein, and the deficit 9 grams of protein. This is calculated based on 24 recall method. She takes both vegetarian and non-vegetarian food, and there is no history of consumption of raw milk. Socioeconomic status: she belongs to according to modified Kupusamy scale, she belongs to upper middle class family. There is no overcrowding in the family.
Nitya, slow down, talk slowly. Thank you.
They have sanitary latrine and drink purified water. To summarize, a 11-year-old girl with history of blood transfusion and IV iron transfusions in the past, and easy fatigability, poor intake and weight loss for the past 3 months. Now she is hospitalized for anasarca and abdomen for the past 1 week.
Dr. Viswanathan, can you take the lead in questioning these?
Yeah, please. Nitya, just go back to your. I just want to know. When you said this IV red color, some red color infusion, does that mean, what do they mean by that? Do they mean blood, or what do they mean exactly? The red color
IV iron infusion, sir.
Okay, fine. Right, okay. I just want to know, in the history, you say this anemia, isn't it? Is it right?
Yes.
Correct? Anemia. And then that's the main thing. And 40 days ago, I had generalized edema. Do you think anemia itself can cause generalized edema here?
This presentation, this edema is not alone because of this anemia, sir.
Okay. Another thing I want to is this history of blood stained stools, one episode, and it's 1 year ago. Do you know a bit more about that? It is only one episode. During that time, that 1 year ago, did she have any other symptoms apart from this blood stained stools? Is there anything else going on at that time?
No, sir. According to the mother, she had one episode of bloodstream stool. Further, she has gone to the hospital. There, they found that she is anemic and she needs blood transfusion. She is hospitalized for 3 days, had a 1 unit of blood transfusion, and then she is discharged. And she's after that, she was not on any oral medications.
The reason I'm asking this question is because 1 year ago, actually, the problem has started, looks like, because she had a significant anemia. That is, people wouldn't have given a blood transfusion at that point of time. And the thing is, they did not have diarrhea at that time. Was there any weight issues at that point of time? We need to know that. That's the reason I'm asking this question. Because though the history is now 3 months, but I think that there's something's going on for the last 1 year or so.
Yes, sir.
Yeah, and the other thing is the diurnal variation of the edema. Just go back to the first slide. What is the relevance of that? What is the relevance of this? Particularly about diurnal variation. What is the relevance of that?
In case of nephrotic syndrome, when the child gets up, there will be increased periorbital swelling. As the days pass by, the periorbital puffiness it's reduced.
Okay, thank you. That's fine. And this is a girl, no? This is a girl child. Yeah, okay,
Yes,
fine.
sir.
Another thing I want to know is you did mention about no any exercise intolerance, any breathing difficulty, anything like that. Correct? Am I right?
Sir, I haven't
No breathing
said
difficulty.
that in the.
Yeah. Okay, that's fine. I just want to know. That's what I want to know. Any breathlessness or exertion, I want to know particularly.
So it was not there, sir.
Yeah, because the reason, why you need to know that.
Because it may be because of due to the cardiac causes,
Yeah, and then
anemia with whether she is presenting anemia with failure, congestive
yes.
cardiac failure.
Okay, that's good. Another thing is, where is this child? Which part of is it from Trichy or somewhere else?
Nearby which is Ariyalur.
Ariyalur, okay. Listen, did you ask for any history of recurrent blood transfusions in the past, anything like that? Because you're saying
No, sir.
abdominal. No,
There's
anemia.
no history of no history of blood transfusions in the past, sir.
Do you know why I'm asking that question?
Because he had one episode of blood stools, repeated blood, any hematology, to root any hematological cause of
Yeah,
anemia.
but though it's a bit late because 11 years, you would have proceeded a bit earlier if it is going to be significant hemoglobinopathy, anything like that. Okay, I know that you have mentioned nicely about yellowish discoloration of eyes. What is going on in your mind here? What exactly is going on in your mind?
To rule out any chronic liver disease or liver pathology that causing this anemia and edema.
Okay, fine. And the thing is there anything else you want to say? Because this problem is going on for 1 year, at least I would say, not 3 months, I would think. And something has happened before 1 year. And you did mention about this problem of jaundice, of yellowish discoloration, etc. Urine. Is there anything else you want to ask in this context? Is there anything else you want to ask here?
Any history of how she was before and any history of bloodstained stools previous episode, any other bleeding manifestations, other bleeding manifestations other than the bloodstained stools,
Like?
hematomesis,
Yes, and?
epistasis, hematomesis, hematuria.
No, yeah. But other thing is, what I'm talking is in context of liver disease, also ask for melena also. Because we don't know now whether you're dealing with which system, we don't know yet. So when you're asking questions, you can also ask something, because the duration is quite long, whether she had any sort of complications of the underlying disease also, you can ask some history pertaining to that. That might also points towards an underlying cause. Okay.
Yes.
And you did mention about vomiting, not an issue. And fever, any particular reason of asking fever in this particular case? Anything you want to think about it?
It's a duration of 3 months. So with the fever, we can think of any other infectious causes or some malignancies, underlying malignancies.
No fever at all in the 3 months period. No fever at all.
Sir. No, sir.
Okay, so what do you think about infection? When you mean infection, what do you think?
For past 3 months duration, I will think of chronic infection like tuberculosis.
Okay, and anything else? You did mention about the malignancy. What malignancy you are thinking about?
Any lymphomas.
Okay, fine. And this loose, you did ask about the altered bowel habits, loose stools or constipation. What's going on in your mind? Why you want to ask this question?
To ask for any inflammatory, look the history for inflammatory bowel disease.
And okay, okay, fine. That's okay, fine. And this reduced urine output, high colored high colored urine, rash, etc.? What is it going on there?
Renal causes of edema, sir. Renal
Okay.
causes of edema.
And the rash, what particularly rash you want to ask? Why you want to ask the rash?
Rash is for two reasons. One is to root henoxypyrin purpura. It can present with abdominal pain, edema, and rashes, purpura.
But 3 months duration, 3 months bit unlikely, isn't it?
That's unlikely, sir.
Yeah, but
Even
what?
even inflammatory bowel disease, the child can present with rashes.
Yeah, that's okay. Very good, very good. And the reduced urine output and high colored urine. You mentioned about renal cause. What particular renal cause you're thinking about here?
Nephrotic syndrome.
Okay, fine. And the thing is, yeah, you did mention nicely about the breathing difficulty. We did particularly want to know the exertional intolerance also, and then yeah, and the other thing is. And you did mention about rash in the context of inflammatory bowel disease. So you could also ask some other history pertaining to extra intestinal manifestations of inflammatory bowel disease. What things you would like to ask for?
Any swelling, redness of the eyes,
Okay, very good. Anything else?
joint swelling,
Yes, very good. They may have joint swelling or they may just have arthralgia, just a joint pain. Okay, anything else?
right. Oral ulcers,
Oral
abscess
ulcer.
ulcers.
Okay, very good. That's very important actually. That's one of the important thing you need to ask for. Anything else? Okay, you have a child who is 11-year-old. You told that she's losing weight. Also, she is not. She's having abdominal distension, pain, etc. Is there anything else? Any other group of symptoms you want to ask for? You did think about the etiological causes like cardiovascular, renal, liver. You didn't think about it. Also, you thought about the abdominal TB or also inflammatory bowel disease. You thought about it, and we did discuss briefly about hematological causes. Though this is unlikely presentation here. Apart from that, I did mention, apart from the etiological causes, also you need to ask something about which also helps to narrow down the etiology. I did mention about the complications of liver disease, hematemesis, melena. Also, you could ask about, history of, history suggestive of malabsorptions also. Okay, like also
Vitamin
talking.
deficiencies, history regarding vitamin deficiencies.
Yes. That yeah, that's you could ask that history also. And I know you mentioned about the diet history because I want to know a little more in detail because especially whether this is before 1 year or before 3 months, was the child nourished very well? Any problem with weight? Any with the weight actually? Leave alone weight loss. Was the child growing appropriately until that period of time? Until 1 year of age? I mean, until 1 year ago or 3 months ago? Was there any issues about the growth? I just want to know that.
According to what mother felt is, until she goes to school, she was, when compared to her peer group, she was almost equal to their weight and age. But for the past 3 months alone, she noticed that she has lost weight. All her dresses, which were used to be very fit for her, has become very loose. So she's concerned about the weight loss only for the past 3 months, sir.
Okay, good. Thank you. You did mention about, etiological infection also you thought about it. Is there any other infection you want to think given this history? Apart from TB?
Inflammatory bowel disease,
Infection, talking about infection.
worm infestation, sir.
That's not going to present like this typically. Yeah.
HIV, possible HIV.
Yes, HIV, don't miss it, okay? Because this is one thing we shouldn't miss it actually. Any sort of child presenting with weight loss, abdominal pain, we don't know what we are dealing with. We shouldn't miss HIV at any point of time actually, okay? Because if you miss it initially, you may miss it actually. I don't want that to be missed actually. Okay, fine. Just go back to the first slide. Let's make sure that we have discussed everything.
Dr. Jason Uni sir, can you hear me? Dr. Jason Uni sir.
Yeah, next one. Next slide, please. We say this 1 week acute onset abdominal pain. What do you think? What could be the reason for acute abdominal pain here? So Dr. Uni is there. I think he wants to say something. Dr. Jason Uni, sir. We can't hear you, sir. We can't hear you. Okay. Let's go down. So what is acute onset abdominal pain? You're saying acute onset. What could be the reason? What is going on in your mind here?
Based on this history, I would think of in this ischemia. So because of this ischemia, she could have got that pain.
It's a possibility, yes, very good. Or could be some sort of obstruction. Is it possible? Could it be some sort of obstruction possible?
By this time, if there is obstruction, should have vomited multiple. So vomiting should be there, constipation should be there, but it's not
Absolutely
there.
right. You are right. So it could be a subacute process rather than acute process. Thank you. Very good. Next one. Next slide. Yeah, we discussed about this one. Next one. Yes, thank you. Next one. Yeah. Immunization. Yeah. Okay. Immunized till date. You did ask us. Okay. Fine. And the no blood transfusion family members. And when you mean no blood transfusion, what's going on in your mind here?
Not hematological causes, or whether the family members is also affected the same.
Okay. And altered bowel habits.
To look for family history of any inflammatory bowel disease
Okay.
or celiac.
Yeah. And the contact with tuberculosis. Do you get the history of positive contact history all the time?
No, sir.
Okay.
No, sir.
Yeah. Okay. Next one. Yeah. Thank you. That's fine. Okay. Yeah. Next one. Yeah. We did discuss about this. Fine. Thank you. Next one. Yeah. Okay. That's fine. I think Dr. Challai, sir, Dr. Suresh Challai, sorry. If you want to add anything, please do that.
Yeah. Now with this kind of history, when you said high colored urine, what is why did you mention high colored urine and nephrotic syndrome? That those two don't go together.
Yeah.
Possibly nephritic, sir. Romonephritis.
Okay. Okay. Nephritic onset
Set
of
nephrotic
nephrotic
syndrome.
syndrome is a possibility, but 3 months is
Duration
a little
cycle.
too long for high colored urine. And that should be quantified. That high colored urine should be quantified as to initially later, but she didn't have any. But like Sir said, do you think this entire problem is because of this anemia? Because throughout your presentation, there is one history of blood transfusion, one history of iron transfusion, and presumably with your history, you're going to tell us that this child is paid. No, do you think the edema is because of this anemia? So started that.
We can't hear actually.
Do you think
Because she is having some blood stained stool.
Sir, Dr. Suresh Challai, we just missed the last question because there was internet error, I think. Can you please repeat what question you asked?
No, the question is this edema explained only by anemia that you have described, or is there another cause for this anemia, for this edema now for the past 1 week?
The edema is because of this anemia. It's mostly anemia because of this gut pathology, sir. I strongly suspect gut pathology.
This history.
This history of 1 year duration, stools, weight loss, easy fatigability, poor intake.
Yeah, could be, and because of hypoproteinemia. But do you think the diet alone is the issue here? I want to know whether the other child who's there in the house is well nourished, or is it poverty of, because you said upper middle class, so there should be no dearth of food. They should have enough food. And you
Actually,
said
the mother, even she gives the food, the child is not ready to take it. The issue with the mother is she's having severe loss of appetite.
Okay, so the loss of appetite is one of the issues, more than the loss of food. Including the loss, in addition to loss of weight, is severe loss of appetite. And so, what would cause this loss of appetite? When somebody comes and says they have loss of appetite and loss of weight,
some chronic inflammatory.
any inflammation. But what is in your history not going, not congruous with inflammation?
No.
All throughout this period into the mother, so little incongruous there, inflammation, but yes. For the end of history, what do you think the problems are? How would you like to give us a differential?
It's a chronic illness of 1 year duration, anemia with hypoproteinemia, requiring the anemia is that severe, it's requiring blood transfusion. So So probably she is losing blood through the gut. So primary intestinal pathology. So I would think of chronic inflammation inflammatory bowel disease, tuberculosis abdomen, celiac disease.
Once again, Dr. Nitya, we can hear your voice nicely, but Dr. Suresh's voice, we are not able to hear properly. Sometimes Dr. Suresh's voice is breaking.
Okay.
We mean some other panelists, other participants also have mentioned that. Yes, please. Yes, thank you. And just Dr. Ramachandran wants to know what's the progression of the swelling details. How many days after facial swelling, abdominal pain, and leg swelling? Do you know the progression of the swelling?
Progression of edema.
Yes, sir. Initially started only over the face. Mother noticed initially she has minimal facial puffiness. Later she noticed the edema was progressing to the foot. Till the foot it was.
So initially over the
It started only with the face. She noticed a child who was lost weight.
okay, fine. And also in the context of rash, we want to know whether there is any history suggestive of SLE rash also. That's also you can ask for that. And hair loss, Dr. Ramachandran sir mentioned, and vision disturbances. Sir is asking for vision and sleep disturbances. Is there anything else? And also pica. Yeah. Okay. Okay. Fine. Yeah. Carry on, Dr. Suresh. Please, if you want to add anything, please carry on.
That's fine. In your differential, you feel it's a gut pathology. Any other differentials you like to use with the history of your summary is here. IV blood transfusion, IV iron transfusion, fatigability, poor intake, weight loss, anasarca, abdominal pain. With this, you said it's chronic intestinal pathology. What else? Is there anything else you would like to?
Malabsorption.
Malabsorption.
Probably due to intestinal causes.
Okay. Malabsorption syndrome. With no diarrhea at all.
That's very rare.
Less chances. Without diarrhea, can we have malabsorption syndrome, sir?
Usually unlikely. But again, celiac can present because nowadays we see more of constipation rather than diarrhea, particularly in Western countries. But in our country also we can see. But again, celiac, the presentation is not consistent with celiac actually here. But especially those which are predominantly, the duodenal environment, they can have, not necessarily to have diarrhea actually. But again, the celiac in this particular child is a bit unlikely because, but anyway, we'll discuss that.
Fine, sir. I'm not.
On general examination, she was lying comfortably supine in the bed. She's conscious and oriented. She's pale.
We have plenty of time. Talk slowly because everyone has to understand. Those who are participating, talk slowly. Okay.
On general examination, she is lying comfortably supine in the bed. She is conscious, oriented. She is pale. There is no icterus, no cyanosis, and no clubbing. She had periorbital edema, facial puffiness, and pitting pedal edema. That's at the level of ankle, and there is no sacral edema, presacral edema. There is no significant lymphadenopathy. On head to foot examination, a hair, lice, and nick were present. She had glossitis, cheilitis, and leukonychia. SMA stage 1, BCG scar is present on the left deltoid region. Her skin throughout the body is normal. There is no rash, no joint swelling, no perianal abscess. Vitals. Heart rate is 86 per minute. It's regular in rhythm, normal in volume and character. No radiofemoral radial delay. All the peripheral pulses are well fed. Capital refill time is less than 3 seconds. Her pulse volumes are well felt. Blood pressure is 100/60 in the left upper arm. Measured in the supine position. It's between 50 to 90th centile. Saturation 90% in room air. Respiratory rate is 20 per minute. And her temperature is 98.6 degree Fahrenheit. Anthropometry. She weighs around 21 kilogram and it's less than third centile. Her weight is 129 centimeter and she's between third to 10th centile. And her BMI is 11.54 and she's underweight for her age. On systemic examination, on periabdominal examination, on inspection, her abdomen is distended, flanks are not full, umbilicus in normal position, skin over the abdomen is normal, There is no dilated veins, scars, sinuses, no visible pulsations or peristalsis. Her orifices were free and her genital is normal. On palpation, abdomen is soft, warm. There is no organomegaly. Tenderness felt over right iliac fossa and her abdominal girth is 48 cm. There is no abdominal wall edema. An ill-defined mass is palpable over the right iliac fossa. The borders could not be made out. It's tender and uniform in consistency. There is no rebound tenderness and no guarding in rigidity. It's not falling forward and it's not moving with respiration and there is no visible pulsations. On percussion, her liver span is 9 cm, that is normal for her age, and there is no dullness. On auscultation, bowel sounds are heard and there is no bruit. Other systemic examination, central cardiac vascular system, first and second heart sounds are here and there is no murmur. Respiratory system, bilateral normal vesicular breath sounds are here, there is no uttered sounds. And central system, she is conscious, oriented, and there is no focal neurological deficit. To summarize, a 11-year-old girl with history of blood transfusion and IV infusions in the past, and 3 months history of VC fatiguability, anorexia, and weight loss. Now she is admitted for anasarca and abdominal pain. On examination, she is found to have she is underweight for her age with pallor, anasarca, and features of hypovitaminosis, and ill-defined mass over right iliac fossa is felt.
Yeah. Dr. Jason Uni has joined here. So shall I proceed? You want to say something?
Yeah, I wanted to say, so from this history, what is your impression of this case?
Go back to history. Go back to the history. Summary is history.
No, I know the history. I've seen the whole case.
Okay.
What is your first impression of this case?
So it's an illness of chronic duration, sir. It's an illness of chronic duration, primarily involving the gut intestinal pathology.
Why do you say that?
Because history of 1 year duration. She has been admitted for only with the complaints of 1 week, but she has an illness requiring blood transfusion 1 year back. So the illness started from there itself at her 10 years of age. Requiring.
So what is your? It's a chronic illness. Okay, you say it's a chronic.
Illness.
So next, what else?
Primarily involving the gut because she's underweight. She's having loss of appetite. She's having features of hyperproteinemia, anemia with hypovitaminosis.
Is it Kwashiorkor? It's severe energy malnutrition.
No, sir. It's not because of she don't have.
What is the mid-arm circumference? You haven't checked the mid-arm circumference. I didn't see a mid-arm circumference. Do you know mid-arm circumference is age 11 years?
No, sir.
No. So what? How do you rule out subacute? I mean SAM, severe acute malnutrition in this case?
It's not because of the nutritional deficit, sir. It's because of the underlying illness. She's underweight.
But what is her nutrition status like? There's a deficiency in her calorie intake and her protein intake, no?
It's not because loss of food. It's because of she can't eat the food.
But still,
So-
you can get a secondary. You can get a SM because of that. How do you rule out SAM in this case?
She's in case of Sam Kwashiorkor, her sensory will not be. She's conscious oriented. She will be irritable in case of Kwashiorkor.
Okay.
And there is no skin changes like
How
what's
long
seen
does
in
it take for
Kwashiorkor.
skin changes come in Kwashiorkor?
It may take 3 to 6 months.
Yeah. Do you think this is an acute? The edema started when?
She has been admitted previously 40 days before for the same complaints of edema, sir. So almost after 40 days of this edema, this is the second episode she's been admitted to hospital for similar complaints.
Yeah. So 40 days of is it enough to produce the skin changes and hair changes? Is there any ascites? You haven't mentioned ascites.
There is no ascites, sir.
You've done shifting dullness. How do you check the shifting dullness?
First, I will introduce myself to the child. I will explain her what I'm going to do. Then, making her lying comfortably supine, I will explain what I'm going to do. Then I will expose, with her permission, I will expose her abdomen, and from the umbilicus, by making her lying supine, from the umbilicus, I will do focus and look for where the dullness is felt. Then I will mark that point. I'll ask her to lie in the other side.
Okay,
Then
okay.
I'll wait for 1 minute.
Why do you think with this general anesthesia she doesn't have ascites?
This hypoproteinemia may not be that severe to cause ascites.
With hypoproteinemia and so much of fetal edema, you should expect some ascites, no?
Yeah, that's bit unusual. That's we'll discuss. Yeah, we have to discuss that. Yeah.
Okay, what is the abdominal finding you said? What is the feel of the abdomen?
It's soft, sir.
Soft.
Soft.
There's no doughy feeling. There's no distension. What is the abdominal girth?
48 centimeters.
How is that? What is that like for a child of 11 years?
Abdomen appears to be distended only, sir. On appearance, it appears to be distended.
Okay. What else do you find on the abdomen?
We also noted an ill-defined mass over the right iliac fossa.
So what's your so there is some sort of hypoproteinemia due to some cause. You say it's not subacute SAM, and what is the cause?
Because of chronic inflammation, because of chronic inflammation, she may be undernourished, sir.
What chronic inflammation?
Underweight.
What chronic inflammation?
I strongly suspect chronic any intestinal tuberculosis or chronic inflammatory.
Why intestinal tuberculosis? It's such a difficult diagnosis to make. Intestinal tuberculosis in the beginning. When you make a diagnosis of intestinal tuberculosis, how do you make a diagnosis? So difficult to make a diagnosis. How do you say put that as a first diagnosis? What else could it be?
No, so I would like to give differentials: intestinal tuberculosis, inflammatory bowel disease.
Okay, what mass in the right iliac fossa? What else could it be?
Probably some lymphoma.
Okay, lymphoma. Any other lymph nodes?
Appendicular mass.
Yeah.
No, appendicular mass.
Appendicular mass, you should say. Most that. See, when you have a right iliac fossa mass, it could be an appendicular mass. So that should be your first diagnosis. Why you think of tuberculosis first?
Because appendicular mass will not present. They will not come to have all these.
No. Suppose malnutrition, there's edema, and then she's got some infection. How do you rule out appendicular mass? Why is that not a differential?
Because the site of the mass, site iliac fossa mass, so we have to.
Right iliac fossa mass. So you have to think about some pathology there, no?
Yes.
Okay, so what else is in your differentials? What else is there? Does lymphoma produce such hypoproteinemia?
Unlikely.
Very unlikely. Very unlikely. So hypoproteinemia, there has to be either a loss of protein. What are the cause of hypoproteinemia in children at 11-year-old?
Probably it could be renal causes like nephrotic syndrome.
Yeah.
Or intestinal liver disease causing hypoproteinemia.
Yeah.
Or protein losing enteropathies causing hypoproteinemia.
Yeah.
Or malnutrition itself causing hypoproteinemia.
Okay. Okay. So here you have an 11-year-old child. What are the causes of hypoproteinemia in an 11-year-old child?
With the history, I have ruled out
What
renal.
age group for nephrotic syndrome?
Usually it's between 1 to 10 years, sir.
What are the two peaks of minimal change nephrotic syndrome?
One is between 1 to 10 years.
Okay. 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 Then hyperproteinemia. Other causes, you said liver. Why is it liver pathology not considered?
Because there was no history of jaundice.
You need a history of jaundice to say a liver pathology causing ascites, and see, there's no ascites. That is the main thing.
No ascites.
There's no ascites.
Yes.
There's no liver. Liver, you didn't get a liver size, no?
Yes.
What is the size of a liver in your child?
Its liver span is 9 centimeters, sir.
9 centimeters enlarged.
No, sir. Liver span is 9 centimeters.
Span.
Liver is not enlarged. Liver is not palpable.
Liver is not palpable. How do you get a span, liver span? How do you assess the liver span?
By palpation, first I will mark the lower margin of the liver.
How do you get
Then-
the lower margin of the liver?
From the right, after explaining what I'm going to do and introducing myself, I will, after exposing the abdomen, I will, in the supine position, with the legs being hip and knee flexed, I will palpate from the right iliac fossa with my index finger parallel to the right costal margin. I will slowly, with every inspiration, I will just move my fingers. I will move towards forward. Then I will, where I can feel this resistance, it's the lower border of the liver, sir. Then for the upper border, from below the, I have to focus and I'll feel where the dullness starts.
Where do you start focusing from?
From the second intercostal space, right side second intercostal space.
Okay. And then
And then we have to mark both the upper and lower border, and we have to measure how much it is.
okay. Do you check the upper border in inspiration or expiration?
Inspiration, sir.
Okay.
Even
So
in
then-
that inspiration will take. So.
What about the left border of the liver, left lobe of the liver?
It's not palpable.
Well, okay. So the liver is not enlarged.
No, sir.
Yeah. So when you have a mass on your right side of the abdomen, how do you check for shifting dullness on that side?
Down, not we are not going to look at the site of the mass. Below that, we have to check, sir.
No, you check on the left side. Why do you want to? You can check on the left side. See if they're shifting on the left side. When there's mass which is on the right side, your dullness you'll get because of the mass, isn't it? So you can say that you can see. We'll check on the left side. Why not?
Yes, sir.
There's no spleen.
No, sir.
No spleen. So you got a diagnosis of probably a chronic illness, whatever the chronic illness, and hypoproteinemia, malnourishment. What is the nutritional status you said again?
Sir?
What's the nutritional status of this child?
She's underweight for her age, sir.
How underweight? What is the BMI?
11.46, sir.
11.4. What is it for the age? You put in the BMI chart.
Less than third centile, sir.
Less than thirds of BMI. Huh?
Yes, sir.
So she is malnourished and
Yes,
she's
sir.
got edema. So that's why that the first diagnosis should be malnourished child, which probably maybe developing SM. How many children with tuberculosis have you seen who develop this hypoproteinemia like this and generalized anasaka?
3,
Pardon?
3, sir.
It's common.
The question is it common?
No, sir. It's not common, sir.
This is very unlikely. See, tuberculosis causing this sort of malnourished, this hypoproteinemia with Anasaka. So there is some nutrition deficiency, definitely. She's got anemia. She's got, you said there was Quilinicia or Platinicia. What is that, the nails?
Leukonychia, sir.
There was leukonychia. So what is that? Anemia. So she's got anemia. She's got vitamin deficiency. She's got Anasaka. She's got hypoproteinemia. So definitely there's an element of. So your first diagnosis is malnourished child, no? And then what the causes are at 11. So somewhere she's losing protein or she's not eating enough, isn't it?
Yes, sir.
So lymphoma node comes very much lower down, and she's got some infections.
Yes,
What is that? Earlier she had some bleeding PR.
she had one episode blood stained stools, sir.
That is when, so many years.
1 year ago. 1 year ago.
What is that? Is it related to this?
Yes, sir.
What is the relationship?
She's losing small. She's having chronic blood loss that's causing this anemia.
Why is this chronic blood loss? Is it a inflammatory bowel disease?
Probably could be, sir.
So is that part of the diagnosis? Protein losing enteropathy.
Yes, sir.
You put IBD as one of the causes.
Yes, sir.
So that maybe those things have to be considered because she's losing protein somehow. So tuberculosis to cause malnourished so much of edema is not. I haven't seen so much of tuberculosis causing so much of edema. Okay, so now what about you do from this time onward? So you got a child who's got generalized Anasaka, hypoproteinemia, vitamin deficiency, anemia. Probably there is some nutritional or loss of protein somewhere, or intake is less. She's had vomiting. How long has she had anorexia?
For the past 3 months, sir.
Could it be anorexia nervosa?
But she's not. There is no history of any vomiting. She's not rejecting food. She can't eat food. She likes food, but she can't eat food.
You can't eat food, can be anorexia nervosa. What are the systems that can be involved in anorexia nervosa? What is her mental status like?
She's conscious oriented, sir.
Is she a happy child, or what is the situation at home?
She's a happy child. Only for the past 3 months, mother noticed she's not interested in outdoor games and all. Otherwise, she's very cheerful. She used to play, most of the time, she used to play only in the outside with her peer groups.
What age can you get anorexia nervosa?
She's in adolescent age, sir.
I see adults in now.
Yes, sir.
What are the systems that are involved in anorexia nervosa?
Endocrine.
Almost every system.
Yes, sir.
No, it can affect the kidney, it can affect the heart, it can affect almost every system is involved. So you can get a malnourished child because of anorexia nervosa. Why not that be a diagnosis?
If that's a case of why should have a blood transfusion 1 year ago, sir? Because for the past 3 months only, mother is saying she's not eating.
Okay.
But before 1 year before itself, she had these transfusions and all. So it started before this.
Yeah. Okay. Fine. Okay. So it probably is inflammatory bowel disease is possible. She said, can you explain with your tuberculosis diagnosis, bleeding PR?
Why I'm thinking tuberculosis is we are in India. We are very much here almost. We should never. We should
Never
not
had
think
fever.
of.
But she's never had fever.
No, sir. No history of fever, sir.
No fever at all. Oh, tuberculosis without fever. How many tuberculosis have you seen without fever at all?
Maybe mother have not noticed that much, sir. But there is no history of fever. After on admission also, she had no fever. And when we asked the mother also, she didn't complain any fever.
Yeah. So tuberculosis without fever, it's not having fever ever. She's had a BCG scar.
Yes, sir. She had, sir.
BCG has been taken.
Yes, sir.
And immunization status is by the National Immunization Schedule, no?
Yes, sir.
National Immunization. She's completely immunized.
Yes, sir.
Okay. So yeah, tuberculosis without fever, you're having some mass in the abdomen. To make that as the first diagnosis, I don't know. Okay. So then what else do you do from there on?
So first I would like to do.
Just one second. Nitya, just go back to the slide, the examination slides. I want to have something. Just go back to examination. Yeah. Go back. First slide.
Yeah.
Just go back to the first slide, please. Examination. Yeah. The previous one. The next one. Sorry. Yeah. Sorry. I'm sorry. Just the previous one. Okay, fine. Next bit. Here, SMR. What do you mean by SMR here?
Sexual maturity rating, sir.
And what's the other name? Other term it's called?
Tanner staging.
Then carry on. The reason I'm asking this question again is, we need to know whether there's a delayed puberty, etc. That's the reason, because you have a child who's chronically malnourished. We don't know exactly, as Dr. Jason Muni said. I think we should know. I know that it's upper socioeconomic class. It's very unlikely to be, a poor nutrition by, due to non-availability of food, anything like that. But still, we need to think about that. BC Jiskari, you mentioned, that's fine. So I would not mention the parental abscess here. I tell you why I won't mention it here, because you won't do that just like that all of a sudden there. Okay, just next slide. Okay, this one. In your examination presentation slides, there is one thing which is missing. It has to be there for any pediatric examination case, and particularly for this one, it has to be there. You know what it is? There's one thing which is missing in your examination slides. Growth chart. You should have a growth chart. Though you have put it, you should put a growth chart. Okay, next one. And also, you should always try to look at the growth chart. If the patient had one, you try to look at the growth in the first few years or whatever it is. That's very important. Yeah, I know you put it one, but you have to put the growth chart. That's very important. Next one. See, I just want to know about, I know you did mention about shifting dullness. What are the various you will assess for ascites in a child? Because you may be dealing with an ascites here, but you may not have picked up. I just want to know what are the three types of examination which you will assess for fluid in the abdomen. What are the things? Can you say?
For minimal fluid collection, we can look for with puddle signs, sir.
What is that? How do you do that?
We have to, after explaining the procedure to the child and getting her consent, we have to ask her to lie prone for 5 minutes, and then we have to ask her to get up in the knee elbow position. And if there is fluid, it gets collected around the umbilicus with the help of the stethoscope, or we can focus and look for the dullness, or with the we can move the stethoscope from laterally and we can look for the dullness.
Okay, basically, there is when you have the fluid there, it's going to be dull, and then you'll go to the tympanic area away from that. Okay, and shifting dullness you discuss about that. Any other thing you look for to assess? Use a massive effect.
There is I will look for fluid thrills.
How do you do that?
After explaining the procedure, I will ask her to lie supine and the knee flexed. I will keep I'll ask any one of my colleagues to keep their hand at the level of the midline, and by keeping my one hand on the other side of the abdomen on the left leg fossa, with the other hand the right leg fossa, I'll give a gentle tap. If there is gross ascites, I can feel that thrills.
Okay, and why do you want to keep your hand in the midline?
To prevent the transmission.
What? That's why you're going to see even fluid cell. Why you're keeping the hand in the midline? You just do not have the transmission to the fatty lane. You just want to have a proper thing to the water, whatever it is inside. And you ask for dilated, you look for dilated veins. Any particular reason? What are you looking for here?
Dilated veins, look for signs of portal vein hypertension. Sir.
Okay, that's fine. And here, after looking the hernial orifice genitalia, that's the time I look at the perineal area. Perineal area, you can just put. I always say nowadays to my students, Abdomen 10 quadrants, I will say 11 now, because I always have the, after looking genital examination, I always want to look at the perianal area. What are the things you look for the perianal area?
Perineal skin tag, fissures, abscess,
And fistulas.
plus.
So you put it here. Okay, that's very important. Okay, next one. Yeah. Abdominal wall edema. What do you mean by abdominal wall edema? And why do you look for that?
She had a facial puffiness.
Yeah.
There is no ascites, but to make sure there is no abdominal, we made sure there is no abdominal edema. Sir.
Again, abdominal girth here, I need to know the serial value rather than one-off value. One-off value is not going to tell me anything. I need to have a serial value here. Okay, next one. Okay, and you find a mass over right iliac fossa. I know that there is a mass there. You could say something about, you mentioned about that. That's fine. There is no reboundedness guarding region. That's very good. You mentioned that. That's good. Okay, next one. Liver span. Is this normal for this age or not?
Yes, sir.
What is it? Do you know the liver span for different age group approximately? Okay.
For her,
Yeah. Tell me.
for the urge of 11 years, 9 centimeters normal, sir.
Okay, that's good. Fine. That's fine. No problem. Okay, next one. And I'm a bit puzzled. You mentioned that she's anemic. Did you not hear even what is a short systolic murmur? No, that's a bit surprising, isn't it? She had, I don't know, we'll come back to that. I don't know whether what was the hemoglobin at admission, I don't know. Usually we hear some sort of murmur there. That's okay. Fine. Next one. And what do you mean by anasarca? The word anasarca, what do you mean by that?
Generalized edema.
Okay, fine. Fine, okay. That's actually a significant, we are talking about a significant edema actually. And actually, I am also puzzled that how come we are not having an ascites when you're thinking about an underlying tuberculosis causes as a probable etiology, but there is no ascites, but there is a significant edema. We'll come to that. Okay, thank you. Yeah.
So my final diagnosis is chronic intestinal inflammation, probably due to chronic inflammatory bowel disease or intestinal tuberculosis with anemia, hyperproteinemia, underweight, and post-cholesterol performance for the past 3 months.
Post-scholastic performance has been there from how long?
Only for the past 3 months, sir. She's not interested. She's not reading.
Why do you call it post-scholastic performance then? Is it learning disability?
No, sir.
Why?
Because previously she was able to learn. She's a good academic student. For the past 3 months, she's not interested in her academics
Because of the illness. So
because of the illness.
scholastic performance is secondary to the illness.
Yes,
Why do you put that as a diagnosis? Is it a part of the diagnosis? I don't think you put that there. Scholastic performance. Anyway, how do you look for abdominal edema? You said.
We have to give a gentle pressure over the abdomen, and we have to see. We have to keep it for 5 to 10 seconds, and when we take out the hand, we can see the pitting over it.
But you'd say inspection first, now.
Yes.
Inspection. How do you say for abdominal wall edema?
Palpation we can make it out. So by inspection we can't.
No. Inspection findings for abdominal wall edema.
Suppose you got a tight garment. On.
Stretch.
And what about the umbilicus?
For this child, it's normal question, sir. If there is ascites, it
No,
becomes
I'm asking for abdominal edema. The inspection findings.
umbilical will be smiling.
Okay. What is a fistula? If there was a fistula, what did you suspect? Hemorrhagic fistula.
There is when we strongly suspect Crohn's disease, sir.
Okay. So that was not there.
Good.
Genitalia?
Get to normal, sir.
Okay, so you're now again saying probable TB as the first diagnosis, huh? your final diagnosis after your clinical examination?
I can't exclude by now, sir. It can be TB or Crohn's, either of these. I have to investigate, then only I can come to a conclusion, sir.
Okay. Okay, let's go to the investigations.
I would like to complete blood count to look for the anemia, how severe the anemia is, and ESR, peripheral smear to know what type of anemia it is, stool for occurred blood for any chronic blood loss, liver function test to look for hyperproteinemia and how the liver enzymes are, ultrasound abdomen, first to know how is the right iliac fossa, how about the right iliac fossa mass, and is there any minimal ascites pre-fluids are there. Then I will, based on this, then I will proceed the other investigations, sir.
And I want to have one more investigation here, at least one more investigation in this particular slide. What is that? Definitely in this slide, I want to have one investigation at least.
Go back to your preferences and find the.
I want a urine routine here.
One of the
So that
differences.
we are dealing with it probably, but I just want to know a basic thing. Whether there's any proteinuria, I want to know. Yeah, that's that thing I want to hear in this slide. Okay, and the ESR you mentioned. Yeah, okay.
You'll not do a gastric juice for AFB?
It's a bigger child, sir, 11 years old, so we can have an induced sputum in this child. This bigger child, she can cooperate.
Got cough? Has she got cough?
No, sir.
But you take induced sputum and there's no cough at all. Are you going to get against sputum?
We can give salbutamol nebulization with 3% cell nebulization, and we can ask her to cough out, and we can try for that, sir.
Very unlikely you'll get. There's no cough at all. Okay. Okay, then carry on.
Go on, Venus.
Based on this, then I will to rule out to know whether it's tuberculosis or Crohn's. Then I will proceed with man-to test, chest X-ray, colonoscopy, and I will see how the lesions are. Based on colonoscopy, around 40 to 50% we can come to a conclusion whether it's tuberculosis or Crohn's. But even with the colonoscopy, we can't come to. I mean, in 50% of cases, we can't conclude with colonoscopy. So I will send tissue biopsy also for gene expert and the culture.
Okay, I'll
How
come
much
to it.
weight loss has this child had over the last 2 months, 3 months?
Sir,
Weight loss. How much weight loss has this child had?
mother, actually, since the last investigation, mother has not checked her because of COVID reason. She has not checked her the rate recently. But mother had noticed that her dresses have become loose. That's what mother knows, sir.
Could it be malignancy? Is it possible? Some malignancy somewhere? Other
But
than
1 year duration is very unlikely in case of malignancy, sir. Any malignancy, the two taking a longer duration is very unlikely.
And what sort of malignancies we are talking about here?
He's having right iliac fossa mass, so probably some lymphomas, sir.
And what else you would have seen in examination?
Any other lymphadenopathy, some other, but there is no significant lymphadenopathy elsewhere, sir.
And also liver spleen are not well.
Not well.
Those all things also matters. Okay. The
could
relevance
be a
of
kidney
mass-
mass, kidney malignancy. Got a mass in the right.
No, sir, it's not palatable. It's in the right iliac fossa
Okay.
and not.
No, there's no hematuria. Yeah, okay, fine. Okay. What are the deficiencies you look for? Vitamin deficiencies you look for?
From in the eyes, I look for vitamin A deficiencies, sir. White hot spots, conjugal cirrhosis, corneal cirrhosis. Then I look for in the skin. I look for any vesicular scaly lesions like for zinc deficiency, perioral perianal dermatitis. Then cheilitis, stomatitis for vitamin riboflavin deficiencies. And for 11 years old, I look for vitamin D. I look for a house of very, but she has grown, but still I look for any metaphyseal widening for rickets.
And I think the good thing is differential diagnosis. So far, we have discussed everything. Is there anything else? I know Dr. Muni mentioned about malignancy, etc. Lymphoma. Is there anything else you want to consider in this particular child? Is there any other differential diagnosis you want to consider in this particular girl? It's a clue there.
Connective tissue.
Sorry.
Connective tissue disorder.
No. Okay.
With a mass.
I'm talking about an 11-year-old girl.
With a mass.
The mass.
11-year-old girl with an abdominal mass. Girl is the clue here.
11-year-old girl with a mass. What is the other?
Pelvic mass. What?
Ovarian.
Yeah, think about it.
Ovarian tumor.
Just think about it. It's not very, but just think about it. Just because that has to be there. Yeah, carry on. And the relevance of mantra in this particular child, how is it going to help me? How is it going to help you? Is it going to help you? Is it going to be positive, or how you are going to interpret that?
MAN2 is to look for any latent tuberculosis bacilli infection alone, sir. With the MAN2, it's not, with MAN2 we can't come to a conclusion. Because MAN2 positive doesn't indicate that there is disease, and there is negative doesn't rule out the disease also.
So do we need to do that at all? Shall we just leave that? Do we need to do that? That's my question. Okay, chest X-ray.
Yes, sir. Because with intestinal tuberculosis, some children can have coincidental pulmonary disease also, but it's very unlikely in her because there is no signs of cough and cold and other symptoms of pulmonary.
What percentage of abdominal TB can have an associated pulmonary involvement?
17 to 40%, sir.
Approximately 20%. Okay, that's fine. Okay. And peripheral smear, apart from what do you want to look for peripheral smear? What are you looking for?
What type of anemia it is, whether it's microcytic hypochromic anemia or megaloblastic anemia.
Okay. Any abdominal you can look for also. Okay. Stool for occult blood. I'm not a big fan of it, honestly. If there's a blood, there is blood. If no blood, it's no blood for me. That's it. Okay, carry on. I'm not against it because if there is tiny bits of chronic GI loss, you can do that. I'm not against it because there was history of blood in the stools 1 year ago. Okay, yeah. Okay, ultrasound abdomen we'll do first, then we'll decide about that. And is colonoscopy enough?
It's a colonoscopy, sir.
Is colonoscopy enough?
No, sir. We have to do a colonoscopy and take tissue biopsy from the site of lesion, sir.
Is colonoscopy alone enough and tissue biopsy colonoscopy enough? Question is again specifically, is lower GI endoscopy enough? No, it's not enough. I tell you what, we'll discuss that. When you are subjecting a child or a pediatric age group for any sort of colonoscopy, particularly when you're thinking about a possibility of inflammatory bowel disease or ileocecal tuberculosis, we need to check the upper GI tract also. It's very important. I do not have two different procedures 2 different times. Okay, upper GI endoscopy along with colonoscopy will give us a clue what's going on. When we say colonoscopy, we always say ileocolonoscopy because I've seen people, particularly going to the adult gastroenterologist, they look up to cecum, they don't go into ileum. It's very important they go to the ileum also. It's ileocolonoscopy and same time upper GI endoscopy. We will discuss that. So that is, then of course we need histopathology. Yeah, carry on. Yeah. And urine routine, I definitely want it.
Yes, sure.
Yeah.
Next slide.
Dr. Suresh Shalaya, sorry, sir.
Yes, sir.
You want to add something?
No, Why did you not put this urine here in this slide? Was there any reason you didn't put up urine in this slide? Because that is something that we commonly do for almost everybody that comes into a hospital.
No, sir. I thought in this child, renal hyperproteinemia due to renal cause is very unlikely.
At the end of your clinical
I didn't
examination,
suspect nephrotic syndrome much.
by the end of your clinical examination, you didn't still have a firm reason for this hyperproteinemia that you described. So I think a urine should have been put there. It is an oversight, if anything. But was there anything in the urine that you found?
No, sir. No.
Yeah. And this liver function test, do you want to do the entire liver function test, or is there anything in particular that you want to look for in the liver function test?
I want to look for protein and serum albumin, but if with TB, I'm going to start her on ATT. So I want to know her baseline liver enzymes, how her liver enzymes are, so that will help me in the treatment. So I need not prick her again.
That's excellent answer actually. Yes, you do the full thing. That's an excellent answer actually. Yeah, you should do it. That's better you do it rather than poking these children, 2 or 3 times. It's better to do it full liver function test. Thank you.
Good, good, good. Fine, sir. I'm fine. So, do you want the results of the investigations that they did, sir? We go on to the results. Show the results. Next.
Shall
Yeah,
You show your investigation results. Yes.
results.
Her complete blood count, hemoglobin is 8.9 gram per deciliter, and total count 10,400. Differential count, neutrophils 57%, lymphocyte 32, basophils 0.9 with monocyte 7%, and eosinophils 1%. Her RBC is 3.82, ESR 90 mMH per hour, PC is 26.7, MCV is 78, MCHC is 33.3, MCH is 26, platelet count is 3 lakhs, MPV 6.4, and RDW is 27.8. Total protein is 3.6, and her serum albumin is 1.5 grams.
What is striking here?
She's having hyperproteinemia.
Yeah. A significant hyperproteinemia, isn't it? Yes.
Yes.
What is the reason here? The likely reason.
Because of this protein losing enteropathy, she's losing her proteins.
Yeah. And so is she having a problem in the intestine? That's what you're trying to say.
No, sir. She has 2 issues, sir. One, she's losing protein and she's not taking also. Both is contributing to her low serum albumin level.
So when we mean albumin is 1.5, the globulin is around how much is it? 2.1 something? Yeah, 2.1. There is also a reversal of the ratio. Is it true reversal of ratio or just because albumin is low?
It's because the albumin is low.
That's what I also think. Because sometimes when there is any sort of chronic disease, you have a this sort of albumin reversal. But I think this is predominantly a low albumin actually. That's the main thing I could see. And the ESR is very high. ESR high, pointing towards anything in particular?
There's some chronic inflammation is ongoing, sir.
When you have a ESR of nearly 100, what are the 4 conditions that you always want to rule out?
Kawasaki, tuberculosis, connective tissue disorders,
And malignancy.
things.
4 conditions. Near 100 ESR persisting, especially in a child who has fever, you have to consider these 4. This absence of fever is very funny. No fever at all. Ever this child has never had fever.
That's really funny. I agree with you. That's you say that there was no history of fever at all. That's bit unusual actually, honestly.
No fever, no ascites. Both are unusual.
And we are having a very low albumin, and there is no urine proteinuria, and there is no clear history of malnutrition. And anyhow, okay, we'll come to that.
That is why it was malnutrition. Malnutrition was the first thing that should be.
I think Dr. Uni, your point is very valid. Anorexia nervosa, I think, point is very valid actually. I think we should think in this direction also, particularly in this era, particularly from upper socioeconomic status. We have
COVID times. I've seen so many anorexia nervosa that.
I think it's a very valid point. I'm seeing one. I'm managing one for the last 1 month.
So difficult to manage these children, because this child doesn't look like. I mean, you got a diagnosis of tuberculosis because you have maybe a finally you have a.
Nitya, why we are saying anorexia nervosa? Can you explain the edema and anorexia nervosa?
Because she's having, it's not because of malnourishment, she's having food, she belongs to upper socioeconomic status family, she's having food, but she may refuse to eat food. It's not because.
No. The question is, can you get edema in anorexia nervosa?
Yes, sir.
But not to this extent. You know why you get edema? Do you know?
Because of reduced protein intake.
And you have to go and read something about the refeeding syndrome, but not now. We'll discuss. You just go and read it. Okay, refeeding syndrome. But anyhow, that's one of the important things we need to think, especially upper socioeconomic status, a girl child around teenage group. You have to think about that also. Yeah, carry on.
If you're thinking of anorexia nervosa, do you think, or even a psychological issue, do you think something else could have triggered this in these times where children are staying at home? Anything else could have triggered this issue? Would you like to, again in this era, think about that? At least ask about that, or
Very
anything
difficult.
else? Girl child.
One thing is very much against is blood in the stools and significant anemia needing transfusion. That's one thing definitely against.
But the transfusion was 2 years ago.
No,
1
year
year
ago.
ago, sir. 1 year ago, sir.
And after that, she didn't have any other transfusion.
No, sir. She had 40 days ago admission. She had two infusions of IV iron, sir. Intravenous iron infusion she had, sir.
Why is this IV iron given?
At that time, 40 days ago, though, she had complaints of generalized edema. She was hospitalized in some other hospital. They found she's having anemia, so they have given IV iron infusions at that time.
Do we give IV iron like that in pediatrics? I don't know. Why wasn't a transfusion given then?
Because they had found that the loss is because of it did not be the anemia may not be that severe to give a transfusion immediately, or they have found she may not she can't take oral. There is some gut pathology she can't, so oral is not can't be tolerated, so they might have given an IV infusion, sir.
And anorexia nervosa, there's one issue you can ask her whether what she thinks about her body image. Okay, that's one thing you can ask. Okay, carry on.
Okay. So from this investigations, what do you come to?
Go ahead.
Got a high ESR and anemia and hypoproteinemia. That's it, isn't it?
Yes, sir.
Okay.
Next slide.
Further, next slide.
Her MANTO was negative. Stool for gallbladder was also negative. CECT abdomen showed.
No. Before CECT, I want an ultrasound picture. Ultrasound.
What is the ultrasound picture?
Okay, don't worry. The reason I'm asking ultrasound is easy test to pick up ascites. It will give some idea, good idea about the liver, gallbladder, everything. Definitely, I want to know something about ultrasound. And most of the sonologists nowadays, pediatric trained sonologists, will pick up, the terminal ileal pathology. They may not pick up to this section CECT, but always put the ultrasound abdomen first. Especially, I want to know the ascites. Okay, yeah.
Yeah, that's fine.
CECT abdomen. It showed diffuse bowel wall thickening involving the distal ileum, ileocecal junction, and colon with luminal narrowing and perilesional inflammatory changes, multiple intra-abdominal necrotic lymphadenopathy. And CP-net tissue biopsy showed mycobacterium tuberculosis and with no rifampicin resistance.
Where is this from? Where is this? When you mean tissue biopsy, where is this from?
It was taken from the distal ileum, sir.
What are the colonoscopy?
Yeah, always. I just want to know the macroscopic findings, not only the histology findings. I want to know what did they see on colonoscopy? What was the colon like? And what was the ileum look like? What was the ileocecal valve? That's very important. That gives us a clue. Basically, ileocecal tuberculosis is very difficult to make. You have to put everything together. Then only you can come to a diagnosis. Okay, definitely you should put on a urine routine examination. You should put an ultrasound. And especially before CE, CT, abdomen, I want to know the renal status before I go and give a contrast. That's very important. Okay, I need to know the urea, creatinine, whether they're fine. Okay, carry on. Yeah.
And histopathology, the cecal biopsy showed ulcerated colonic mucosa with granulomatous inflammation.
What is the colonoscopy
Ulcerated
findings?
colonic mucosa. I want to know a bit more about any other information they've given. This granulomatous inflammation, it's not very specific, honestly. I want to know a bit more, a detailed report of histopathology. And I want to know, I'm very much interested to know the colonoscopy, macroscopy findings and ileum. Because the reason I'm asking this question is, that gives us a clue whether we're dealing with Crohn's disease or ileocecal tuberculosis. Okay. In Crohn's disease, I will see a lot of abscess ulcers. I will see troubleshooting of mucosa, pseudopolyps, more of a serpiginous longitudinal ulcers. And I see more of a, pancolitis in children. Maybe you can have involvement of left side of the colon, and also the transfers on the right side of the colon. Whereas in tuberculosis, I see more of the involvement of the right side only. Majority of the time, cecum and the ileocecal valve and ileum. And you may not have involvement of the distal colon. But the thing is, this child had blood in the stools 1 year ago. So she might have had some left-sided features, but I want to know that. Other thing is, TB usually is a transverse ulcers. I want to see whether the ileocecal valve is patulous. All those things are very important. We need to do the macroscopic findings. Okay? Yeah, carry on. Is it over? Next slide.
You have the colonoscopy findings. The colonoscopy did show some patulous ileocecal valves, sir, but I don't remember the other exact colonoscopy findings.
Okay.
The patulous ileocecal valve was something that struck my mind at that time, and it was mainly in the ileocecal junctions. He had said that there's nothing in the left side at all.
Yeah, and thank you. And Dr. Ramcharan mentioning that extrapulmonary tuberculosis like spinal intestinal present without fever also. That point is taken, and you may have a child without fever also. And anemia and edema as a major presentation of tuberculosis is unusual, but you could have anemia, but edema, without any ascites is a bit unusual, honestly. Edema, you have edema, you are sick with hypoproteinemia, but you don't have ascites. So the entire clinical picture should be explained only by a protein losing entropy due to the problem within the lumen. That's the only way we could explain in this particular child, that because of the significant involvement of the ileum or probably the subpart of colon, mainly the ileum I'm talking about, she is losing a lot of protein in the stools, and that is the reason she's having hypoalbuminemia, and that is the reason she's having edema. But in this context, usually I expect some ascites, but it's been very unusual here. But that's okay, that's fine, and that's what finding you have. Yeah, and what else you want to say? You want to know a bit more about it. I want to know, did you start treatment? What's happening with the progress of the child? Did she respond to the treatment?
Yes, sir. She responded well, sir. We started her on ATT, and she's on regular follow-up. Every month we did her liver function test, and she's compliant to the drugs, and she has gained her weight. Repeat.
What is the regimen you are giving?
Sir?
What is the regimen you are giving?
4 HRZT, 2 HRZT plus 4 HRE, sir.
Okay. Yeah, there's another question there. How will you assess the protein loss in the stools?
By looking for fecal alpha-1 antitrypsin levels, sir.
Yeah, what will happen?
Usually, it's not lost in the stools, but if it's high, it indicates some significant protein loss is there.
Yeah, but it's not available everywhere, but it's available in certain labs. Is there any other test you would do in this child?
Stool test.
Because I mentioned that in history, but you didn't say that in your investigations at all. I was discussing that this you should think, but you didn't mention that in investigations. It's very important, I will say that.
Immune deficiency.
Go back to investigation. Because I did mention that what else? Yeah.
Urine complete, I had done, sir.
That we have discussed. Anything else?
See, because this child has got
Renal function test.
no,
Yeah,
no,
yes, we discussed that.
any immune deficiency that can cause you think of in this condition.
HIV, sir.
Yes, it has to.
Antiretroviral.
HIV has to be done in this child. You want to know that? Please do check it if you're not done already. And
Before colonoscopy, for all children, we used to do a serology test, sir. It's done and it was negative, sir.
thank you. And I'm sure you have done the COVID test also. Thank you. I'm sure that because we don't know what we are dealing nowadays. Everything we have to think about COVID. I'm just saying, joking that, but this is not. I'm just saying that. Okay. And yeah. Anything else? Any other test you would do? Any other test?
Any other stool test you want to do?
Yeah, that's very specifically, doctor. Yes, you asked. Yes, thank you.
Stool test for your one of your differential is IBD, in idiopathic inflammatory bowel disease. To look for inflammation in the bowel, there is a particular stool test which
Fecal calprotectin.
Yes, that will help us in a way, but not too great, but that will give us a clue. But okay, that's important. I want to know the upper GI endoscopy finding this child also. I tell you why. We need to know that. Okay, next time, whatever it is. Okay. And the thing is, I know we are sure. You know why I'm still saying that. You know, in Crohn's disease, approximately 30% of them do respond to ATT initially. Then only we will know what it is. Because Crohn's and idiopathic tuberculosis, we should try to do whatever we can do to narrow down to get it. Because initially, Crohn's, approximately 30% do respond to ATT. Then we know what's going on. So if you look at the upper GI endoscopy, you have stomach involvement, if you have a dural involvement, if you have some findings there, it's more pointing towards Crohn's rather than tuberculosis. But anyhow, you have done all these things, that's fine. Is it in culture? Did you get the culture report?
Culture was negative, sir. Gene expert was positive, but culture was negative, sir.
Okay, fine. And then what is the medium they use for culture? No?
MG,
Huh?
sir. Mycobacterium.
No, I know.
Growth indication.
The medium, what is it called?
Liquid medium, sir.
That's called LG medium, lowest in Jensen medium. Okay, fine. Okay, that's important. Just you know, I don't think it's very important, but just know that. That's it. And so, what are the ways? Do you have some time here, or should we have to close? Or we have to ask Dr. Jason to say, what are
You can go up to 9:30, no problem.
Okay. So if Dr. Jason wants to say something other, because I will be discussing some more actually. If Dr. Jason wants to say something, he can say. Then I will discuss something.
No, you carry on. I'd like to. There's another meeting I have to attend. Can I leave? You can carry on.
Yeah. Okay. Thank you.
This we have a mother and baby friendly hospital initiative evaluators thing going on. So anyway, very good presentation. I think you've done very well. You answered a lot of questions. I think the differential is something that you need to sort of be more clear about. Differential diagnosis when you come to from physical examination itself. The differential diagnosis should be much more broader than what you said. That's the only thing that I wanted to emphasize during this. Otherwise, the presentation is good. Investigations, you will never get to investigations in your clinical examination. It's only in your clinics, in practicals. It's only your examination, clinical examination, and how you approach that case from your clinical findings. That's all that's discussed. You will not go to most of these lab findings and all that because by the end of that, your assist, your approach. So that broader differential diagnosis should be there for every case. You can't put this. I was very upset that you put tuberculosis as the first diagnosis in this particular case. So that's something that I wanted to emphasize. Anyway, good presentation. All the very best in all you do. Thank you very much, Suresh and Dr. Bala, Dr. Rajendran, and all of you in Tamil Nadu. I'm so sorry that I have to leave because the last portion of that, at least I have to attend the other meeting. Please. I hope you.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you.
Sir.
Thank you so much.
Thank you. Nice seeing you, Dr. Jason.
Yeah, same here, Suresh. Be nice. We'll meet up sometime.
Yes, yes, next time.
Bye.
Physical meet. We'll meet up. Bye, bye. Thank you.
Thank you, sir.
Okay, just we go back.
Yeah.
So before I go and say more of the tuberculosis and Crohn's, so what do you do better next time? So what is the learning point for you from the presentation today? You tell me first. I tell you first of all one thing. Actually, you did an excellent presentation. Okay, you have went through everything. You answered most of the questions nicely, and you did think about all the differential diagnosis in the right way. And your presentation is very good, and your slides were very good. I should say that first of all. Thank you. And what do you think you could have done differently, or what do you think you could do next time better?
This I would have ruled out the complications. I have not included the complications of the disease in the history, sir. That would, next time I would add up.
Yeah, that's history. Yes, good.
Then regarding with the diet and with the history, I should have asked regarding the anorexia. I didn't think about anorexia nervosa in this child. With this blood stains.
Yeah, we're slightly earlier, 14 years, 15 years, yes, but 11 years slightly, very early, but still just think about it. But very unlikely here, very unlikely, because you had a history of blood in the stools, anemia, transfusion, etc., etc. But anyhow, okay, yeah. Do you know by any chance at the time of transfusion, what was the hemoglobin at that time? Any idea? Okay, don't worry. Yeah, carry on. Yeah.
No?
You don't shake your head, say it.
Yes, sir.
Say the answer.
Carry on.
What else to do? Different.
In the general examination, I have not added the perineal lapses, sir. As you told, from the next time I will add it in the inspection or.
That's not a big mistake. That's not a big mistake. Just I'm saying that's okay. That's fine. Okay, yeah. But just to make it easy, we're not going to perineal and then you're going to come into abdomen. Just the abdomen, genital, groin, perineal. Finish it in one go. Yeah, carry on.
And chronic duration, I should not miss HIV.
Yeah.
You always include that.
Now you have to mention that in history. You have to put that in your investigation. Even if you've done it, unless you put it, I will not know that. I will not believe that. Okay, carry on. Yeah.
And in the investigations, I didn't add up urine complete. We did, but
No problem.
I didn't add it here.
Yeah, and the thing is, I think so. Is there other PGs there also? I just want to know because there are other PGs who have joined. Let me ask them also whether they want to say anything different. I just realized, is there anybody? I think there are two other PGs. No, I just want to ask them.
Yes.
Is there anything else you want to say? I know that you guys have joined. I thought that I could involve them. You also. Is there anything else you want to say? One is this is Nitya. This is Abhinaya. Is that what's Abhinash? What's the name? Abhinaya. You want to say anything? Do you want to add anything, or what do you want to say?
I have mentioned only the one value of abdominal girth.
Unfortunately, I can't hear you in the mask. Yeah, carry on. Tell me. Then Nitya can translate your whatever you say. Yeah, tell me.
So we have mentioned only the one value of abdominal girth. We have mentioned it in the serial values.
Yeah, that's very important to know that. Yeah, that's okay. And anything else, the other person, anything else you want to say? Okay, that's fine. So I want to know a bit about this ileocecal tuberculosis since you have mentioned about that. And what is a typical way it involves? How does ileocecal tuberculosis involve? I just want to ask these other two ladies, then I will come to Nitya because Nitya would have studied to a great extent. I know that. I want to ask these other two ladies. Sorry, I didn't get your name. Abhinaya, is that right?
Abhinaya, Nimisha.
And
Nimisha.
Yeah, please say. Is there any? What do you want to say about ileocecal tuberculosis? How common? What are the ways ileocecal tuberculosis is present? I mean, let me put it like this. What are the ways abdominal TB present? Let me ask this question. What is abdominal way? How does abdominal way present? Abdominal TB. What are the ways it present?
So we can present as ileocecal tuberculosis because in ileocecal
Okay.
junction or present as lymphadenopathy.
Yeah.
Peritoneal involvement.
Okay, fine. Next person.
Then
So,
with
Nitya, you want to finish? Nitya? Yeah, you say, yeah. Tell me.
strictures and any signs of obstruction.
Okay. Nitya, do you want to say that? You want to summarize nicely? Or how does abdominal TB present? What are the 3 ways it present?
So it can be either ways. It could be either ulcerative, hyperplastic, or ultra-hyperplastic. If
That
it's
is,
a case,
that is bit of the, you're talking more of the intestinal tuberculosis as such, but I'm talking about abdominal TB as a whole abdominal TB. What are the ways it can present?
it can present as abdominal distension, abdominal pain.
Yeah, it can present like this. What I'm trying to say is it can have intestinal involvement, which is GI tract involvement, or it could be just peritoneal involvement, or it could be lymph node involvement.
Nodal involvement.
This is not small.
The way it is, that's the way. Yeah, you tell me now the clinical features.
So based on the site of involvement, it can be, the symptoms varies. If it's an intestinal tuberculosis, most commonly presents with abdominal pain, abdominal pain, loose stools. Sometimes if that is stricture, it can present as an acute presentation like intestinal obstruction. In case of visceral involvement, they can present as organomegaly. If there is peritoneal involvement, it can present with adhesions. It can also present like intestinal obstruction, or nodal involvement can cause lymphadenopathy.
Ascites. Don't forget. Ascites. Okay, so you are right. So the most, some are non-specific things like, this fever, weight loss, anorexia, pain. These are all a bit non-specific, but they are very commonly seen. Particularly also fever is noticed. But as the other persons tell that we can have just without fever also. Other thing is very typical of abdominal tuberculosis. I mean, is more of ascites and subacute intestinal obstruction is much more common. When you compare to Crohn's, in Crohn's you have more of blood in the stools. There's a blood in the stools is more likely to be one of the IBD you are dealing with, and more likely the Crohn. I mean, now for the differential diagnosis for TB, it's Crohn's disease actually. In children compared to adults, Crohn's disease presents majority of the time with colitis. When I mean colitis, inflammation of the colon. It can have blood in the stools, and in Crohn's, you have more of a left-sided or throat pancolitis, whereas in tuberculosis, more of a right-sided involvement. And the thing is, and as I mentioned, the other features of colonoscopy feature, I mentioned that. And then in histopathology, what typically you see in Crohn's? Do you have any idea Crohn's? What do you see and what do you see in tuberculosis?
In tuberculosis, we'll see many number of granulomas, caseating granulomas. Tubercles can be seen.
If you are lucky and if your histopathology is good enough, yes, you will get it. Okay. And Nimisha, anything you see?
In colonoscopy,
Histopathology.
about the lymph nodes, whether it is necrotic or.
If you have a lymph node. Okay. The thing is, sometimes I've seen some of they may even pick up the AFP from the histopathology, but that's very unusual. The gene expert, do you know how good is gene expert? Abhinaya?
Abhinaya, sir.
Yeah, Abhinaya, tell me, how good is gene expert in diagnosing this intestinal tuberculosis?
Only 30 to 50% of the gene expert in abdominal tuberculosis is positive, sir.
Do you know how sensitive and how specific it is? I think if you get it, it's good, specific. If you don't get it, the sensitivity is not that good. Sensitivity is not that good. If you get it, you are lucky enough that diagnosis is there. You may not, the sensitivity is not that good at all, honestly. But you have to take this biopsy from the area where you have the pathology, like ileum or colon or wherever it is. And when I do that, I go to ileum, take the biopsy from the ileum for AFD staining, culture, and gene export. Okay. And again, the imaging, will that help? Will that help for in any way for tuberculosis and Crohn's? The imaging wise. When I talk about imaging, let me talk about the lymph nodes. Nimisha, you can say lymph nodes. Is there anything specifically you look for the lymph nodes examination while doing imaging? Is there anything which points towards tuberculosis? Anything points towards Crohn's disease?
In TB, there will be central
Much more confident lymph nodes will be there. Okay. Anything else? Yeah, that's fine. You make it a presentation, and there's a CT or the ultrasound looking at the location of the lymph nodes. Does it help us in any way, Abhinaya? No, the lymph nodes, the location of the lymph nodes, the distribution of the lymph nodes. Does it help us in any way? Nitya, you can say.
So it points towards the site of lesion where it is, the location from site of lesion, because if it's near right iliac fossa, the nodes near the right iliac fossa is enlarged, so the underlying pathology is from there.
Okay, okay, and it could be somewhere in the right iliac fossa or towards draining area, celiac, anywhere that you more points towards ileocecal. And if you find a lymph node in the retroperitoneal area or somewhere para-aortic, what does it tell you?
It's a nodal form of tuberculosis, sir.
Sorry?
It's a nodal form of tuberculosis.
We are talking about retroperitoneal, and I'm talking about retroperitoneal area, or it could be even around the pericaval region or para-aortic nodes.
Malignancy.
You need to think about malignancy. Okay, very important. Don't miss that one. Okay, and ascites. You know this. I know that in this child you do not have ascites. If you have ascites, what did you do? How do you analyze? What you would have done? If you have ascites, what you would have done?
Serum acetic albumin gradient I would have done, and
You
look
done
how
an ascitic tab. You done an ascitic tab.
yeah.
At the same time, you look at the serum albumin. Same time. So what is SAG stands for?
Serum acetic albumin gradient, sir.
So how does it help you?
We can know from that whether it is transferred or exudate. If it's an exudate, if it's low, then probably it could be, if it's less than 1.1, probably it could be because of tuberculosis.
You know, can you just explain that for 1 minute? I'm going to give it time. How do you explain that? Do you know that why it is low? Can you tell me that? So that you will remember that. When you know how things happen, you will remember that for life. What's happening here? You know, this albumin and the ascites, basically is your hydrostatic pressure, oncotic pressure. Because in many of these conditions, in cirrhosis or in heart failure or constrictive pericarditis or portal hypertension, the hydrostatic pressure is increased. So it pushes the fluid out from the intravascular compartment into the peritoneum. So actually, because the fluid is less in the intravascular compartment, you have a high albumin. It's not actually high; it's spuriously high. So because the albumin is high, and in the serum and the ascitic albumin is, because it's only the transitase has got down into the peritoneum, the albumin is less there. So you have more than 1.1 SAG in those conditions. Whereas in tuberculosis, what happens is there will be some sort of proteinaceous material within the tubercles or whatever it is in the peritoneum, and because of that, and actually there is no extravasation of the fluid actually from the intravascular compartment to the peritoneal compartment. Your albumin within the compartment is actually whatever it is, unless there is a cirrhosis when you have a low albumin. So otherwise, that is the reason why you have an albumin higher in the ascitic fluid compared to serum. So the SAG will be less than 1.1 here in TB, whereas more than 1.1 in other conditions. That's what you have to remember. So because this actually has replaced, looking at this adenosine deaminase, whatever it is. This you take in and also you look at the serum albumin and ascitic albumin, then you take it from there. That it would be helpful if the child had ascites. That's the reason I wanted to do an ultrasound scan, just to see what it is like. Okay, that's fine. So that's where we are, and we have got a lot of senior people here. And Dr. Ramchandran asked a few questions actually. Why this child is short? If it is only 3-month history, is it familial? Mid-parental plotting height is important. Plotting of the mid-parental height is important. That is the reason you need to have a growth chart. Okay, I will identify TB nodules in ultrasound scan or CT scan. I think we have to see that. I don't have any specific answer for that, Dr. Ramchandran sir. Nutrition, vitamin, iron supplementation, family screening and follow-up plan is very important. Obviously, if you suspect tuberculosis, you should do the family screening, obviously, for tuberculosis contact here. And well, I think you need to take care of nutrition in this particular child, definitely, no doubt about it. And if you have a Crohn's disease, I would have gone for exclusive enteral nutrition. That's a different talk altogether. I'm not going to discuss that. You are going to supplement with vitamin and iron. And how often you are going to follow this child?
Once a month, sir. Once I start the treatment, then I will explain them the warning signs when they should come back, like signs like hepatitis, signs of hepatitis. Whenever they get a signs of hepatitis, they should come back immediately. Else, once a month they should come, and we have to look for liver function test. And at the end of third month, I will redo the colonoscopy, and I will look for the clinical response also, how she's improving.
What are the? I want to ask the Nimisha and Nimisha first. What are the important things you will take in care in the treatment?
What are they?
Important things you will take care in the treatment of this child.
While starting ATT, I'll also start pyridoxine also, sir.
Okay.
Then other vitamin supplements also I will be providing, sir. Then a proper diet chart I will be giving, sir. After discussing with the parents and the child.
Okay.
Then about the follow-up plan also we'll be discussing, sir. How frequently she has to come and how to monitor her weight, height, and after the treatment.
Okay. Abhinay, is there anything else you want to add?
And I specifically say that the drug should not be missed at any point of time. We should strictly adhere to the compliance.
Okay. I can't hear that. Nitya, can you just say what Abhinay has said?
I will specifically say them they should continue the drug. They should not miss the drug at any point of time.
Okay, very good, very good. Okay, very good. And anything else you want to do, Nitya?
I will warn them regarding the discoloration of urine with the what will happen with rifampicin, because they should not get panic with the next day morning with the red colored urine. They should not get panic. So I'll warn them regarding the.
That's a very good point. Very, very good point. Thank you. Very good. Well done.
May I add, there is something that the Jason Muni said, which you guys missed about treatment of this particular child. You want to do something else. Nutrition, you said, treatment, you said. But what about the
Psychological support. Why she's.
no, the other children in the house? Who's got the tuberculosis? Where does she get this tuberculosis?
We have to look for
Screen
the parents.
Yes.
Screening is important. We have to screen family members to make sure there is no tuberculosis. Nobody has tuberculosis. If somebody has, we should treat them. Screening is important.
I just want now Abhinaya to say that, do you know why particularly ileocecal area is involved in tuberculosis? Any idea? Any logical?
Taste patches.
What? Okay, and then anything else? Okay, fine. Okay, anything else?
Because of the alkaline medium, there is physiological stasis.
Visual stasis is there. Visual stasis is there. There is increased fluid and lactate absorb. There is decreased digestive activity there. There is digestive activity there. And as you rightly mentioned, there's abundance of lymphoid tissue there. These are the postulation. This is the likely reasons we are thinking about that. Okay, fine. And you know that why you get stricture? Why you get stricture? Nimisha, why you get stricture in tuberculosis?
Because of the transmural involvement.
No, actually, it's not transmural. Transmural is much more common in Crohn's disease. Just tell me why. Any other reason? Nitya, you tell me.
So there is intestinal inflammation followed by ischemia in the arthritis that causes the stricture.
You are read very well. I tell you that. Very good. That's the reason. That is the reason you have it. You have ischemia there. You have a stricture. Because of that, you have the stricture. Very good. Well done. Excellent. Very good. And do you get involvement of stomach and duodenum in tuberculosis? Do you get involvement of stomach and duodenum in tuberculosis, Nimisha?
Very rarely, sir.
Very rarely. Do you get, if at all, how do you get it? Okay, that's fine. Okay, that's very rare. Okay, that's the reason why you need an upper endoscopy to look at that. Okay, do you know why it is rare? Why it is rare, Abhinaya? You gave the reason. For other reason you gave. The same reason is that. You
The
gave
reverse
me,
is the same.
huh?
I just think activity
Activity is more.
No. You gave me a reason why it's a common, why common ileum.
Lymphatic.
Is less scarcity there, scarcity of lymphatic tissue in upper GI tract. That's the reason. You did, okay, good, okay. And also, yeah, and peritoneal tuberculosis. I know this child didn't know. What are the ways the peritoneal tuberculosis can present, Nitya?
Ascites.
Yeah,
With frank ascites, I insisted, can we
yeah,
insist? Sometimes like purulent
yeah.
or fibrotic.
This fibroid, yeah, okay, all these things. One of our panelists, Dr. Elias, mentioned that you always should look at the ovaries in this particular child. Okay, that's very important as a differential diagnosis. I mentioned earlier. Sometimes not in this child, but if there's involvement of fallopian tube, sometimes the spread could be from the fallopian tube into the abdominal, intestine. You get what I mean? Or the peritoneum. That is the reason why you need to look at this. Particularly in this child, you are not very sure where is the source, how she got it from. Okay, that's the reason. Is there any one infection which can mimic, which can present like this? Though it's not for this long duration, it's a short duration. Anything else? Those actually more theoretical, actually. I haven't found actually myself, honestly. It's been said in textbooks. They may ask you in exam. That's the reason I'm asking this question. Is there any one infection which can present typically involving the right iliac fossa, pain, some sort of mass, something like that? Do you know that?
Amoebiasis.
Amoebiasis, yes, it's a possibility. Yes, amoebiasis you need to think of. Yes, very good. Anything else? Yersinia enterocolitica. But I honestly, I have not found this, honestly, to be honest. Okay. And most importantly, you need to know this is, abdominal tuberculosis is much more a possibility disease actually. So you may not find the AFB bacilli all the time. So it's a combination of clinical, colonoscopy, ileocolonoscopy, macroscopy, and endoscopy, radiological, ascitic fluid analysis. If you are lucky to have ascites, histopathology, and isolation of the TB bacilli, either from the ABV staining or culture or gene export, or it's from lymph node or from peritoneum, wherever it is, they're lucky to find. Putting everything together and the contact history if you have, or there's evidence of any pulmonary involvement, and if there's a response to the treatment. You put everything together, then you come to a final diagnosis of that. And sorry, I just talked enough actually. And if there's anything else you want to ask, is there any other panelists want to say? We have got all senior teachers here. If they want to add anything, please, they're welcome to do. And if Dr. Suresh Chalaya wants to say anything, please do say, sir.
This is a good discussion. We'll ask Dr. PRC and
Dr. Srinivasa sir is there. Dr. Janani, Dr. Elias madam is there. And Dr. Suri is here. Yeah. Anyone who wants to add anything, please.
I think the discussion went on well, and I think because the diagnosis was tuberculosis was made, maybe restricted for the differential diagnosis. For a girl of 10 to 11, right mass, first she had to also rule out an ovarian mass. We can't do a PV, but you can do a PR, and you have to. So all that has to come. And she's HIV test is not mandatory just because colonoscopy. It is a mandatory. It should come in the first set of investigation itself. Any child of malnutrition, any child presenting with anasarca, loss of faith, yes. So all that is what. Otherwise, she presented well because she was running the solo show, answering all the questions to Dr. Vishwanathan and Dr. Rasan. She did a good job. So I think it's only that the restriction of differential diagnosis, because of a child who had blood transfusion, sick over 1 year and now 3 months sick. So many ladies, you have to think of, and the reversal of albumin and globulin ratio. Okay, in that case, normally we do a PT and we have to look for INR because we don't know. But luckily, I think, as she says, and follow up, of course, she said, first we see after 50, we normally ask them wherever they get the drugs to come after 15 days, then monthly, then after 6 months, after that, then we follow up them for 2 years. And after the second visit, we have to make sure that they are putting on weight and all that. My knowledge about repeat colonoscopy, I don't know. I was not aware of colonoscopy repeat is a must. But otherwise, Dr. Nitya, you did a fantastic job. I know you have passed.
Thank you.
Yes, sir.
I think Nitya should stop screen sharing. Yeah.
Good evening. Nitya and others, you have done very well. So that's first thing I would like to say. Second is, what we are looking at as examiners is how much of the skills in history taking and clinical examination you are trained in this 3 years. It is something like a driving test. Okay, there are certain things which we think we just look whether you have done it correctly. So automatically we look, because these are the things which should be expected to come without much thinking about in this 45 minutes. Okay, in exam, if you start thinking, then it becomes difficult. If you have been doing every day in the ward, in your clinical cases, it becomes a second habit. Okay, so that's why plotting in the chart and other things is not for an exam. It is for every case you must do it. Okay, taking the weight yourself, height or length, whatever it is, yourself, plotting it. And it also speeds up your examination. Once you do 10 times, as they say, no, experience, it doesn't mean the years, it's not how many times you have done, they think. Okay, so you keep on doing it, it becomes, you become competency is very good, so that you can finish it very well in exam. The other problem which we have in exam is, you know everything about the case. Okay, only the examiners most of the time don't know anything about the case. So the examiners will try to analyze from a clinical perspective, from the history analysis, from examination analysis, what is the most likely, what is the logical thinking. So that is a very, sometimes it's a disadvantage for the candidate, because the candidate knows about the case, about the investigations, everything. Those days we were a bit lucky. Our skilled assistants, our seniors will never show the exam cases to us. They will bring them from somewhere and give it to us on the examination day. So we were, in a way, we are lucky. The examiners and we were sometimes on the same wavelength as far as the presentation and discussion is concerned. That is one problem. Okay. So, but we don't know how to overcome this. Nowadays, as a clinician or a subject expert, you do look at the investigations, everything. Only then, but what we are analyzing, what we are assessing here is mainly from the clinical aspect. So you have to change yourself into that mode. Clinically, forget what you was there in the investigation. Okay, you present this case clinically, what are the possibilities I will think of? That's a way you train yourself to look at, time yourself. DNB candidates are in a way lucky. They go to a center where they don't know anything about the case. So they are a little bit more objective, I can say, compared to the MD candidates. So you will definitely have that advantage. So train yourself for that type of examination. Third is, don't forget all the important things. Any case, okay, in pediatrics, you have to have the diet, you have to have the immunization. This is undergraduates you are telling, for you also. You have to project the growth chart. These are the basic things. Okay. And lastly, the final, as you rightly put it in the differential diagnosis, tuberculosis in our country should come in a differential diagnosis of everything. One of my senior or professors used to ask, in any given case, your first question is, why not tuberculosis? Okay, so that's how you have to think. They probably accept a cardiac or something very, very specific. All other things, tuberculosis is a possibility. So you have to bring it in the differential diagnosis. But as our experts are suggesting, think logically, which is more likely, you put it, then you come to the next one. And you can always say that even though the findings are not exactly fitting in, I will consider tuberculosis because it's rampant, some unusual presentation or common things are common. Like this, you can explain. Okay. So it's a very nicely presented and you defended all the questions. You have read well. And that's a very, very impressive thing. And congratulate Dr. Suresh Chalaya for having a good set of students and presenting very well. So it's, the credit goes to your mentors and other your colleagues also. They were also able to answer the questions. And special thanks to MSV. So he played solo. From Vishwanathan Ramamurthy, he became just Vishwanathan. Okay. So he was conducting the whole orchestra. So anyway, he's a master. The good thing is he's trained in UK. So he knows all the clinical aspects. So he gave a very good perspective and very practical information. So thanks to Viswanathan, and thanks Dr. Suresh Chalaya, and thanks IAP TNSC for again taking the students keeping the students in the forefront, being an academy of pediatrics. Thank you so much. I took a long time because there was some time. Okay.
Yes, sir. Thank you, sir. Sir, Dr. Srinivasan wanted to say something, sir. Sir, sir.
I don't want to say. He has Ramchandran has told so much.
They're not audible.
Madam has told so much. So there is Janani. I think they mentioned Janani's name. If Janani is there, she can give her comments. She has been a long DNB examiner for a long time. Dr. Janani, please your comments. She's there?
Looks like she's there, but her phone is muted, sir. So thank you, everybody. I think Dr. Rajendran has had to go away, so let me conclude the program by starting with thanking Dr. Suresh Chalaya and his set of PGs, Dr. Nitya, Dr. Abhinaya, Dr. Nimisha from Kaveri Specialty Hospital, Trichy. I think Dr. Nitya started presenting a very good case presentation, and as the moderators and chairperson and the judges said, she defended her case quite well, and thanks to her, I think we had a very wonderful discussion today. I thank our chairperson for the day, Dr. Jason O'Neill, who really discussed the case in a very systematic manner. And my special thanks to Dr. Vishwanathan, who, as Dr. P.R. Caesar was saying, went on solo and very enthusiastically. So thank you very much, sir. We are very happy to have you here. My special thanks to all the judges, Dr. P.R. Sir, Dr. Jayalakshmi Madam, Dr. Srinivasan Sir, and Dr. Janani Shankar, and DIAP for being here. And then I think as a program, it is difficult to listen every week and make yourself free and be here to listen to the program and to judge them. So they have been doing a fantastic job. The IAP TNSC is extremely grateful to the services of our judges, and thank you very much, sir. I think we can conclude the event for the day and hope to see you next week. Thank you.
Thank you. Thank you, Dr. Suresh Chalaya, for bringing a nice, lot of thought-provoking.
Vishwanathan wants to say anything?
No, I just want to thank Dr. Suresh Chalaya, just because it was a nice case. Thank you very much.
Thank you, sir. Thank you, sir.
Yeah, thank you, MS Viswanathan and Dr. Suresh Chalaya and all judges. Thank you very much.
Thank you, sir. Thank you, ma'am.
Thank you, sir. Sorry, I could not attend. Thank you.
Thank you. Thank you all.
Thank you, sir. Thank you.
Thank you and good night.